And stigma is a very broad topic. And there's many ways to approach it and think about it. So this is how I tried to find a place to begin. And so before we get started, I want you to take a slide, a piece of paper, a little piece of paper, and okay, why isn't it forwarding? Okay, there we go. What happens, what's your first response when you see that word? I want you to write down 2 or 3 words: a visceral response, a gut response, an emotionally honest response, a response that's not politically correct. What is your reaction? I want you to write down 2 or 3 words that is your reaction to that word. And I'm going to flash another one. Don't think too much. We want your first responses to that word, the visceral response to it. So write that down and turn that little sheet of paper over, and we're going to go through the webinar, and we're going to refer back to that sheet of paper, so keep it there. So stigma. As we look at stigma, we need to look at what the definition is. There are a lot of different ones. I feel like for our purposes, this is the best one. It's the perceived, stigma is a perceived negative attribute that causes someone to devalue or think less of the whole person. We'll get back to it. Okay, so as I said, it assigns negative attributes to characteristics, situations, and behaviors of an individual that are not under that individual's control. I can't control what color my eyes are. So it would be assigning something negative to the fact that I have blue eyes when that's not something I can control at all. It's the leading reason why people don't get help, why people with opioid use disorders especially don't get help. They don't want to be seen as one of those people. They don't want the label. They're way more than their diagnosis, as all of our patients are. And sometimes as providers, it's hard for us to remember that. So as Albert and I were thinking about this presentation, we came across an article that we thought was a very good place to start. SAMHSA's Center for the Application of Prevention Technologies last November, so it's very current, wrote an article and did some research, some very good research about stigma, and came up with a good place to start is to change how we talk, how we communicate about the disorder. And so they talk about how language choice can reduce stigma, protest any labels that turn people into things. Sometimes we hear people say he's bipolar. Well, no, he's not bipolar, he has bipolar. There's a difference. He's an addict. No, he has an addiction disorder. People are more than their labels. We need to start looking at ourselves first. Change begins with us. And as providers, we are in a position to begin the change. And I'd like to challenge everyone who's listening to really think about that. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. So that's the power of language right there. I've also heard it said that the only difference between a flower and a weed is a judgment. The difference between a flower and a weed is where it's planted. Here we go. As prevention practitioners, we are in a unique position to reduce stigma surrounding substance misuse. Formally in our jobs or in meetings or whatever it is that we're doing, if we're doing some PR, if we're promoting our program, As part of the messaging in our notes, case conferences, and treatment plans, we need to be sure that we're using non-stigmatizing language. We need to do it informally in our conversations with colleagues and stakeholders. It's really easy and it's fast, and everybody understands what you mean when you say that someone's addicted, but that someone is an addict. But it's really perpetuating that person as a negative label, as an addict, and not somebody who has an addiction disorder. Perception creates reality. We know that. We know that we perceive a person as lazy. It doesn't matter how hard they work. If we have a perception of, it's going to stay and interpret that person's behaviors as lazy. Substance use disorder is among one of the most stigmatized conditions in the US and around the world. I've heard this said, and many of you all probably heard it too. A lot of people just don't want to work with or be related to or even see people with a substance abuse disorder in public. I know that in my own experience, it feels hopeless sometimes to folks when they work with a lot of substance abuse disorder. And we need to really check ourselves and see how our thoughts and our feelings, maybe even very buried, affect how we see that person and what we say about that person, how we might perpetuate a negative image about that person. Many people believe that people with substance abuse disorders can or should be denied housing, employment, social services, and health care. That's when you look at substance abuse disorder as a character flaw. You moralize it versus understanding that it's a disorder just as real as diabetes. We wouldn't tell a person who has diabetes that they really need to get over their dependence on insulin. Once again, we need to start looking at ourselves as we go forward with change. Change always starts with us. Health providers treat patients who have substance use disorders differently. Clinicians have lower expectations of patients with substance abuse disorders. In turn, this can affect whether the provider believes the patient is deserving of treatment. This is all very subtle. We may not even know that we really feel that way until we stop and take a look at it. Some health providers falsely believing that substance use disorders are within a person's control cite feelings of frustration and resentment when treating patients with substance use disorders. Again, we know that perceptions creates reality. We've known that in our business for a very long time. In our industry, we also know that expectations affect outcome. That's not news to any of us, I'm sure. But that's not just on the side of the patient, though. It's our expectations as well as the healer, the provider, the person who they're coming to for help, to understand that our feelings about that person, negative feelings about outcome, can also affect how much energy we're putting into that person's case. It can affect treatment. It's very subtle. And even though we're talking about words here, I want to talk a bit about communication. 80 to 90% of communication is nonverbal. We've known that, again, for a long time. How might we be telegraphing stigma in our behaviors toward a client? I don't know, maybe somebody who's been challenging in your practice and they called, you give a deep sigh that maybe they can hear, it's them again. It's very subtle, but it's pervasive, and it does affect treatment and how people feel about themselves. As prevention practitioners, it is incumbent upon us to do what we can to reduce the burden of stigma. It's important for us to examine and, if needed, change the language we use. breaking the cycle. Here's some tips for avoiding stigmatizing language. SAMHSA suggests that we perform a language audit of our existing materials, your handouts, your program descriptions, your anything that you might have that you use to promote your program or to say what it is you're offering. Be sure that there's no stigmatizing language in them. And place it with more inclusive language. It'll become a little bit clearer as we talk what that exactly is. Are you unintentionally editorializing or adding commentary that would bias the message? Consider that, you know, you could talk to a colleague and maybe you're giving information, somebody needs this information. You say, she relapsed again versus she relapsed. That message is very subtle, but it's there. Again, again, again. Maybe take a look at what we say about that person. We don't need to editorialize about what's going on with them. Every time you develop a prevention message, consider it as an opportunity to dispel myths and convey respect. People with addiction disorders, with use disorders, are more than their diagnosis. We picked up on this in the mental health side of behavioral health a long time ago, that we need to stop calling people their disorders. You know, the person is not a schizophrenic, the person has schizophrenia. Oh, Albert, are you joining us?
I made it.
You made it. Welcome. You can see that I've gotten this far, so I'll keep moving forward, and then when you want to chime in, you can.
Yeah, that's fine.
Okay. Ask yourself, am I maximizing connection, worth, community membership related to substance abuse? Our patients are more than their disorder, and that person might be a mother. They might be a strong member in their community, that they do things for other people all the time. They may be somebody who folks can turn to in a time of need. They're way more than their disorder. We're all way more than our limitations or our challenges. Train staff on issues related to substance abuse and stigma, including important negative health and community outcomes related to perpetuating stigma. And that's true. If we retain the belief that it's pretty futile to try to get people into treatment and get them to stop relapsing, if we keep that belief, if we hold that belief, we're perpetuating the stigma. And again, because most of our communication is nonverbal, you don't even have to say it sometimes. It's just a look or a roll of the eyes or some way in which we perpetuate that. And it's really easy to do because we all work hard, and we all work hard in very challenging and difficult situations with our clients. And you know, we're only human, so it's very easy with my friend who I'm working with to say something negative about a person. Just be really careful.
Absolutely.
How can we explore negative language? We can adopt how we can adopt this alternative language. With careful attention to language, we can reduce the burden of stigma surrounding substance use disorders, improve access to health care for people with substance use disorders, and potentially save lives.
Yeah, and I just want to add a little bit. Can I add a little bit to that?
Oh, I guess so. Yes, you can. Of course.
as we were developing these slides and just having a conversation about language and stigma, one of the things that that we discussed was the terms clean versus dirty. The idea that if you are using drugs or you're an addict, that somehow you're unclean, that you're dirty. And so adopting new language towards that's more strength-based and positive, I think is really important in terms of reducing stigma and really opening avenues for our people to seek effective approaches to treatment. And so using terms like abstinence or positive rather than a negative term, I think is important. So just wanted to add that.
So you reframe that as the urine test was positive for whatever.
Yeah, exactly. So a urine test would be, if it were positive, we would use the language positive rather than saying your test came back dirty, therefore that our client or the patients we work with might personalize that and say and reinforce their shame, their guilt
It
around
implies that they're dirty.
exactly, and then personalize and feel like I'm not clean, I'm dirty. And I know that some of that language prevents folks from returning to your program if they've relapsed or seeking treatment out in the first place.
Okay. So what we say, how we say it matters. Let's get started. So I'd like you to, if you were kind enough to follow the instructions at the beginning of this webinar and write down some words that you had the reaction to. I'll go back to those slides, or maybe I will. I don't really know how to go back. Oh, I do know how to go back to the beginning. What did your gut say when you saw that word? Does anybody want to share? Or, I don't know, can you share on the webinar? Can people talk? Call in?
Yeah, we could either talk or we can use the chat feature too.
Okay.
And everyone can use the chat feature.
Okay, so how many people do we have watching? You know?
We got 5.
5, okay. Of my 5 friends out there, when you saw that word flash, what was your honest truth about what you felt? I know for me, and I'm preaching to y'all, so I know for me, when I saw that word, I got the visual image of a very thin, twitchy male in his 40s, scruffy and looking for a fix. That's what I saw. And I'm up here presenting to you guys, so I've read this article and I've thought a lot about the stigma for a long time, and that's what came to my mind. So I got to put myself in check around that. And the word addict, it's not a noun. It doesn't need to be a name. It's not a name. We don't want to name people an addict or label them an addict. And I don't know.
And I agree. Like Katya, she sent the message that junkie, is one of those words that we see, and that again, that stigmatizing language that speaks to someone maybe personalizing that and feeling again, I'm not worth anything. I'm worthless. I'm no good, right? I'm junk or a junkie.
Yeah, junk. Wow, a junkie. See here. The other one was that one, abuser. That can be any kind of something that's being abused, but just in any situation that you apply that to, an abuser doesn't seem to be a compliment you would give somebody about something. Somebody who uses something or misuses something has a much kinder connotation than have you been abusing alcohol. The other thing that sometimes we don't distinguish between the substance use and the disorder. Lots of people get drunk Super Bowl day who are not alcoholics. So we have, and that behavior that they have might be not very becoming to them. We don't want to label, we don't want to confuse the act of using with the disorder of using. I don't know if that makes sense.
And some of those terms, I've seen someone type in violet, right? Or, bad apple.
Yeah.
And again, the term abuser or substance abuser brings those negative connotations that we may personalize and label ourselves. Again, preventing someone from either seeking treatment or not returning after a relapse.
Shame.
So we as providers need to be aware of that language. Absolutely.
Yeah. So can you see how maybe in yourself there are some maybe subtle and maybe not so subtle ways that you can start thinking about changing how we talk and how we talk to each other? And, I'm guilty of a lot of black humor, gallows humor, dark humor. And I know that I do it to break the tension for myself and to break the anxiety for myself. If I can laugh about it, I can somehow deal with it a little bit better. But I don't know if I always, that's always a service to what we're talking about. So I kind of need to watch myself and, because I can get the room to laugh doesn't necessarily mean that was a good thing. That may have been at somebody's expense. I can't see what people are writing in. Can you see, Albert?
Not anymore.
Okay. Let me see. Maybe folks have stopped writing in. Has this been thought-provoking in any way? Is this, we'd love to have some feedback. It seems like once I got on and presented it, it went really fast. So we do have a little bit of time left, and I'd love to hear some feedback or some thoughts that you might have about this, particularly around perception creating reality. And as I perceive that person as they come into my practice to seek whatever treatment and whatever their issue is, how I perceive them, is it somebody that maybe I've been seeing off and on for years, and how do I feel about them seeking treatment again? Am I hopeful, or am I feeling, here we go again? It's hard for us as providers to keep our energy level up and our attitudes optimistic. Sometimes you feel like you're being asked to be superhuman. But, we can all do the best we can to not perpetuate harmful and painful stereotypes of people.
Yeah, I also want to add that in working with our Native communities, we already understand that the historical and the intergenerational impacts have created this sense of distrust for our more clinical programs or Western approaches to medicine. And so we're careful. In our last presentation, we talked a little bit about, we talked for about an hour about historical and intergenerational trauma in our own states of the issues that we're facing now, especially in the idea of substance abuse or substance dependence and access to treatment. And so this idea of stigma and working with our Native communities, I think it's even more important to pay attention to how we label or the language that we use and to help our people access treatment. effective treatment. And so the idea of medical assisted treatment is, I believe, a great alternative. But how do we utilize our language or change the language so that we're speaking to the population we're serving in hopes that they are open and feeling a little bit more confident in accessing treatment?
Dr. Serrano has asked a really good question. What about balancing avoiding stigma with using the patient's own language? Like if they use terms like addict or junkie or other lingo, and you use their language in communicating with them, and and we're asked to do that in our training. You want to meet the patient where they're at, right? So you don't want to come across as a superior being, but that provides you with actually a teaching moment where you can do what we just did. Just say, what do you think that means when you call yourself a junkie? When you call yourself, use that language about yourself. I see you as a human being and not a junkie. Maybe you have a substance use disorder, but you're not a junkie. You're not that. Nobody's a junkie. You're a human being putting one foot in front of the other on this planet, struggling with a substance use disorder or substance misuse disorder in some cases. Does that help? I think that, without being patronizing or superior, that's an opportunity to teach and to perpetuate change. When you refer to yourself as a junkie, you're really dissing yourself. You're disrespecting yourself. And one of the things that I tell my clients, I don't have losers and junkies in my office. I have human beings who are seeking help. So if you're going to talk badly about my client, who I care about, who's sitting here right now, I'm going to take offense to that, because when you talk badly about yourself, it offends me. You're saying bad things about my client who I value. Does that help? Oh, good. Good. I actually think that those moments with the folks who are experiencing the struggles that they are with addiction or anything else, calling a person diabetic instead of saying they have diabetes, it's just kind of the same thing. Or bipolar, schizophrenic, he's schizophrenic. Well, he has schizophrenia. That's not what he is. And it's an opportunity to validate your client, your patient, and help them with maybe some self-worth issues that they're having by telling them that you value them enough to ask them not to talk that way about themselves in your presence.
And as someone who works in the field but is also walking the red road, we've recognized, even in some of the circles of, let's say, I'll use an example of AA or NA, when you're asked to open up in those meetings, you're asked to identify yourself first as an addict or an alcoholic. And so some of our relatives are not comfortable with that, because they, especially early in recovery, they feel like that kind of reinforces the stigma around shame and guilt, and this idea that I'm going to always be an addict, or I'll forever be an alcoholic, because I have to identify myself like that every time it's my turn to share or speak. And so in our Red Road programs, we change that narrative, and we start to use words like, when we ask folks to introduce themselves, we ask them to introduce themselves tribally first. So it's a part of reclaiming our identity as Native people walking this red road. So I'm a Red Roader, and I'm Miwok, I'm Nisenan. That's who I am first, and I'm grateful on my Red Road journey And so as we start to adopt new language and then share our healing approaches with Native communities, then we start to change that language altogether into more of a culturally based language that helps us to identify healing from many avenues, like historical and intergenerational trauma, but also finding balance emotionally, mentally, physically, spiritually, walking the red road, which is an old way of life, but as we're using it today in our programs of healing and recovery from addiction, and changing that language and the narrative of the language, I think is so important.
I agree. Anyone else have anything to add? We can wrap it up. As usual, both Albert and myself are always available to you if you're in a tough situation with somebody, or sometimes I know in my practice I feel like I've lost a little perspective, or I might be just need somebody else to bounce some thoughts, do a case consultation with. I want to invite you to use me. You can call me, email me. I'll get back to you as soon as I can. And I would gladly offer myself as somebody that you can talk to about something you have concerns about within your practice, or as you start to look at changing the language around substance use disorders. Oh, I don't see it. Hey, Jeff? Jeff is telling me there's another question, but then it's not. I'm so good at this. They're so lucky to have the techno nerd that I am. Okay.
What about addressing stigma within the greater community? There's a lot of desire to distance from people with SUD as a way to show progress in the community.
Yeah, there is. Albert, do you want to talk about that? I can talk about it too. It's interesting that you asked that question, because as I was driving into work today, I was thinking about some of the challenges that we're facing, the barriers to treatment. And we did, Dr. Springer and I did a presentation yesterday, and I overheard two of the clinicians as they left the room saying, yeah, now if they would just come to us for treatment, we would know what to do with them. And I thought, and it's true. It's really true. They feel not part of the healing community, not part of the, a lot of people who feel that way. I don't know. Off the top of my head, I was thinking more gatherings for people with it, hold a gathering for folks who are struggling with use disorders. I don't know. What are your thoughts, Albert? I thought if we, maybe not meetings, but gatherings for people.
Yeah, well, one of the things that we've done here in Sacramento County in making relationships with the broader community is there was a campaign to address stigma and mental illness, and having an opportunity to be a part of the planning on how to reach out to the Native community. We did a campaign. It was a poster campaign. It was a billboard campaign. It was a speakers bureau campaign that still exists to this day, that I felt like was highly successful in reaching out to the broader community, diverse populations, but also within our own Native community. And I felt like that could be an approach that would be equally successful, because I don't see that happening for substance use disorders, right? And I know now with the opiate crisis, there's money that is funneling down for supporting programs like that offer medical assisted treatment. But I think overall, in addressing the stigma for substance use disorders and reaching out to the broader communities, but also diverse populations, I think that we could do a better job in like a campaign similar to the one that we did for addressing stigma and mental illness in our region, working with county and state agencies, as well as the grassroots programs to address stigma. So trainings, right? Develop some more comprehensive trainings around addressing stigma. But I think an overall campaign, similar to the one that we did here in Sacramento, was highly successful. I believe in reaching out, because we're reaching out to the broader community, but starting at, I mean, even doing some street outreach, right, to the homeless, mentally ill, and then within the programs, and then the tribal communities. So my role at that time, I work here at the Sacramento Native American Health Center, as well as contracting with, or actually a staff member now with Talawal Indian Health, and then going out to some of the cultural events, big times, powwows, other trainings that were hosted by Native communities, and actually disseminating some of our resource material around addressing stigma. And I think we could probably do a better job in addressing stigma and substance use disorders, a more dynamic approach. So that's my 2 cents.
Got to get the word out. Every opportunity that we have.
Absolutely. And really a more standardized approach. That's what I really like this, the research that we utilized from SAMHSA. It really spoke to the language that we use and some of the tools to, I think, to really develop these standards, which are already in place for the most part, but I think really developing them for alcohol and drug treatment programs, especially.
Yeah, I would invite you to go to the SAMHSA website and read the entire article and look at the research. It's really well thought out and article and well researched. Got some strong research behind it. It's the Words Matter article. It's just a few pages long. I think that I might, for me, I'm going to print up the article and put it in our packets when I go out giving presentations. I have some of you have it, I know, the folders that that we give to people. I'm going to put it in there because start a campaign, we have to be, I just feel like we need to instill a sense of value to the community that we're trying to treat and reach out to and help on their road and in their struggle. If we don't instill enough self-worth, if they don't have enough self-worth, they're not going to walk through that door to get treatment. So it's a huge, huge undertaking, but we can do it. We faced bigger problems than this and survived. You have anything to add, Albert?
No, I just want to say, thank you for those that have joined us, and apologize for I actually wasn't late. I was actually on the phone listening, but we were having like technical difficulties from where I'm at, and I'm remote from the office. So, thank you for your patience and understanding for that. And I look forward to future webinars.
Yeah.
Thank you.
Please,
you can contact me through my Talawal, the email address as well. But I'm also at the Sacramento Native American Health Center, and access available for either place.
Yes, and there are copies of these webinars on our website as well. So please make use of that. Anything else from anybody? Let me double check and click on this. Sure. It looks like we've answered all the questions and all the commentary, so I want to wish you all a wonderful day. And thank you again for being with us. And
Thank you, Jerry.
Let's hear from you. Okay? Take good care. Thank you, Albert.
Bye-bye.